I'm Eve Rittenberg, and today I'm going to share with you take-home messages and clinical pearls from our Women's Health Talks. I have no financial disclosures. I would like to thank Dr. Pace and Dr. Alexander, who generously shared slides from their own presentations that I've adapted for use today. We were so lucky to have an amazing lineup of speakers today on a wide range of women's health topics. These talks contain the state-of-the-art of research and clinical excellence, aiming to understand the ways in which sex and gender influence health and close the women's health gap, in which globally women spend more of their lives in poor health compared to men. I'm not going to reiterate these presentations, but I would like to highlight some of their key take-home points and add a few of my own thoughts from a primary care perspective. So we will do a whirlwind tour through these topics: cervical cancer screening, medical complications of pregnancy, contraception, medication abortion, menstrual irregularities, menopause, osteoporosis, and interpersonal violence and trauma-informed care. I'll start with our hot topic, which covers the true paradigm shift that has occurred over the past year in our approach to cervical cancer screening. As Dr. Goodman noted in her talk, there have been important changes over the past year or so in guidelines for cervical cancer screening, with a consensus in some areas, but important differences in others. This table summarizes recent updates and guidelines from the U.S. Preventive Service Task Force, or USPSTF, the American College of Obstetrics and Gynecology, or ACOG, and the American Cancer Society, or ACS. First, the similarities. Clinician-collected primary HPV test has become the preferred option for average-risk cervical cancer screening. And a wide range of test options, including co-testing, cytology, and self-collect primary HPV test, are acceptable options. I want to emphasize that primary HPV testing is only for average risk screening, not for higher risk patients or for surveillance after previous abnormal results, because it might miss abnormalities that would be detectable by co-testing. Okay, so there's a consensus, but there are important differences. There are varying recommendations for the age at which to start screening. USPSTF and ACOG continue to recommend beginning screening at age 21, with cytology only until age 30. However, ACS recommends deferring screening until age 25 and then starting directly with HPV testing. And the guidelines also differ in some of the details for self-collected primary HPV testing. So should it be done only in a healthcare setting or also in the home? And at what screening interval should testing be repeated if it's done through self-collection? And finally, although all guidelines agree that adequately screened average risk people can stop screening at age 65, they differ at what we should consider adequate screening. So USPSTF and ACOG continue to recommend any one of a variety of sets of tests over the past 10 years to qualify to stop screening. And ACS, in contrast, radically simplified and clarified this. So stating that the preferred option for adequate screening prior to stopping is 2 negative primary HPV tests, the first at age 60 and the second age 65. And there's some, so there are other options that are allowed, but this helps to make sure that we're not missing people who still need screening. Okay, so after all of that complexity, I want to highlight a major breakthrough in cervical cancer screening that I am really excited about, which is self-collected vaginal HPV testing. And I'm excited because self-collection can address many of the barriers to cervical cancer screening that we've all encountered in our work. Self-collection has a solid evidence base for accuracy compared to clinician collection. And the USPSTF draft update review overwhelmingly found that offering self-collection, usually at home, increased screening rates versus usual care. So before I talk about the benefits of self-collection, though, I do want to mention important limitations. So as I mentioned earlier, this is primary HPV testing. It's only appropriate for average risk patients. At-home options are currently quite limited. They're only available through a single proprietary company at the moment, although there's ongoing research done. Hopefully that will expand options in the near future. And self-collection requires appropriate follow-up in order to be beneficial, and there are some extra complexities in that tracking. But that said, self-collection is so important as a strategy to improve screening, particularly among groups that have historically been underscreened. So self-collection is done without a pelvic exam. It's done by the person themselves with a vaginal swab. And so it can avoid the discomfort that keeps many people from doing cervical cancer screening. We know that the pelvic exam can be uncomfortable, especially for folks with postmenopausal vaginal atrophy or vaginismus. It can be difficult due to physical mobility challenges and can also be re-traumatizing, particularly for people who have experienced sexual trauma in the past. In addition to those important factors, self-collection can be logistically much easier if it's done at home. The patient doesn't have to schedule a leave from work or alternative childcare, doesn't need to arrange transportation, and it can often just be preferred by patients. In addition to those patient benefits, there are also benefits for clinicians. It can free up time that we need to do other care during visits. And in areas that have clinician shortages, it can prevent delays due to long waits for appointments. Next, I'll move to a cluster of topics in reproductive health care. Our women's health session included 3 talks spanning contraception, pregnancy complications, and abortion. And clinician knowledge of these topics is especially crucial now at a time when there's a convergence of legal, policy, and clinical developments that have fundamentally reshaped the reproductive health landscape in the US and globally. I'll start with contraception. I want to highlight a point that Dr. Broughton made to help us effectively counsel patients. This graphic is based on the chart that she showed from Partners in Contraceptive Choice and Knowledge. And Dr. Broughton made a really important point that I keep thinking about, which is that people choose birth control for a range of reasons, not just based on its efficacy. And as a result, to ensure that people find a method that they'll use and stick with and is effective for them, it's important for us to consider this whole range of factors when we're counseling patients on their contraceptive options. And I'll add to this whole sort of menu of concerns that I've heard a lot of concern from patients about pain with IUD insertion, and that issue has gotten quite a bit of play in social media recently. There are updates on pain management with IUD placement, and you can encourage your patients to discuss those options with the person placing an IUD. One of our important roles as clinicians is to evaluate and communicate the safety of different contraceptive methods for individual patients, particularly people who have medical conditions that might increase their risk. This slide is based on one of Dr. Broughton's that shows the historically trusted source for information on contraceptive options, the CDC's U.S. medical eligibility criteria for contraceptive use. This set of criteria uses a 4-tiered classification system to tell about the relative advantages and risks of the different contraceptive options. I will note that the website was temporarily removed by the CDC, then back with caveats, and we'll just note that there's an alternative app that Dr. Broughton showed from the WHO as well. Uses the same 4-tiered system after you input a patient's medical conditions. And everybody should be comfortable prescribing categories 1 and 2. And for category 3, we can review risks and benefits, either using patient-centered counseling ourselves or referring to a complex family planning specialist. And we should be aware of category 4 combinations of medical conditions and contraceptive types to avoid causing harm. And that's a nice lead into the next topic of medical complications of pregnancy. As internists, we often care for women before, during, and after their pregnancies, and there's a lot for us to know to help support a healthy pregnancy and manage medical complications. It was really helpful for me to use the frame that Dr. Shealy provided to think about hypertension, diabetes, and hypothyroidism, 3 common medical conditions that cause complications during pregnancy. So I'll go through the highlights of her recommendations for each of those conditions. Hypertension is a leading cause of hospitalization during pregnancy and poses risk to both the fetus and pregnant person. And pre-pregnancy planning can improve pregnancy outcomes. So as internists, we have a very important role to play here. So what can we do prior to conception? It's important to ask about pregnancy intention when we're prescribing teratogenic medications, such as ACE inhibitors and ARBs, and avoid prescribing or stop them prior to conception. Then once someone is pregnant, our first-line treatments include alpha-beta blockers like labetalol, which is 2 to 3 times daily, or a calcium channel blocker, nifedipine. And the extended release form of nifedipine is dosed once daily, so this can be helpful with adherence. Methyl-dopa is second line, less effective than those first-line medications. We'll note that medicines often will need adjustment during pregnancy and can often be tapered. The goal blood pressure, as shown in the Chronic Hypertension in Pregnancy, or CHAP trial, is to keep blood pressure less than 140/90. Likewise, diabetes poses both fetal and maternal risk. And the key point here is that the risk of birth defects is directly related to A1C at conception. As patients tell us that they're planning a pregnancy, we can make some medication adjustments and use the goal of a hemoglobin A1C less than 6.5, optionally moving to insulin. We should also make sure that blood pressure medicines are adjusted, as I mentioned in the previous slide, since many people with diabetes are taking an ACE inhibitor or an ARB. During pregnancy, insulin requirements will change and the dose may need to be adjusted. And again, during the pregnancy, the goal is to keep the A1C low. So here it's less than 6 if it's achievable without too much hypoglycemia. A quick aside about gestational diabetes, so that we remember to ask about this in all of our patients who have been pregnant. The subsequent risk of type 2 diabetes is so high that regular screening afterwards is recommended. And now our third common medical condition, hypothyroidism, also very common, and we should screen all patients who have a family history of thyroid disease, who have symptoms, who have other autoimmune conditions. And again, there are both fetal and maternal risks. Note that studies also suggest that even subclinical hypothyroidism has risks, and so pregnant women are treated with levothyroxine to achieve a normal TSH, even if they have only subclinical hypothyroidism. And moreover, the goal TSH is lower than in people who are not pregnant. The goal preconception and during the pregnancy is to keep a TSH less than 2.5. We expect the thyroid hormone requirement to increase during the pregnancy, so the levothyroxine has to continuously be titrated, and at delivery, reduce the levothyroxine back to the pre-pregnancy dose. We should then recheck the TSH at 6 weeks postpartum. And I'll move on to our last of the reproductive health topics, medication abortion. Medication abortion has become increasingly common in the US. And we have data showing that medication abortion is very safe, with serious adverse events of 0.5% and a mortality rate that is 13 times safer than childbirth. There's also a growing body of evidence supporting the safety of screening for eligibility for medication abortion by history alone, so without a pelvic exam or ultrasound. And a growing number of medication abortion care is done through telemedicine, bringing access to women in states without access to in-person abortion care. Dr. Bachorg provided some helpful tips on how to provide supportive and unbiased disclosure of pregnancy test results, and then options counseling to patients with unplanned pregnancies, and pointers about symptoms such as severe or unilateral pelvic pain, vaginal bleeding, or other circumstances, including reproductive coercion and intimate partner violence. Then, if a patient chooses medication abortion, we can either be trained to provide this care as internists or refer to another provider. The current standard of care in the US is a mifepristone and misoprostol regimen. However, be aware of changing political and legal landscape developments that may lead to the use of a misoprostol-only regimen. Post-abortion care includes confirming completion either with an ultrasound or with HCG that should drop by 80% 1 week after the mifepristone. And note that urine HCG should be negative at about 4 to 5 weeks afterwards. And then finally, we should be providing contraception if desired. Now I'll move to menstrual irregularities. As internists, we're likely to see people with secondary amenorrhea more commonly, so I'm going to focus on those conditions. So secondary amenorrhea is the absence of menses for 3 months in a person who previously menstruated. And our evaluation aims to uncover the etiology, distinguishing among pregnancy, hypothalamic and pituitary disorders, primary ovarian insufficiency, PCOS, and uterine or outflow tract disorders. We have some key labs, the beta HCG, FSH and estradiol, prolactin, and TSH. The Provera challenge is done, and if there's no bleed, we know that there's a low estrogen state or an outflow tract issue. And a brain MRI is indicated for secondary amenorrhea patients only if there's also headache or neurologic signs, an elevated prolactin, or an unclear history. And a DEXA scan should be done for patients who have more than 6 months of amenorrhea. I'll touch on 3 of the important causes of menstrual irregularities. So first is hypothalamic amenorrhea. The underlying cause is that energy output is greater than the energy input. And this can be from excessive weight loss, exercise, high degrees of stress, either physical or psychological, and or disordered eating. And the first line treatment is to address the cause with the goal of increasing weight. To do this, it can be helpful to draw on a multidisciplinary approach, including psychological support. And in addition, estrogen replacement should be considered after 6 months of amenorrhea to protect bone mass. Guidelines suggest that transdermal estradiol with an oral progestin is preferred over oral contraceptive pills, which can mask the return of spontaneous menses. However, as there may be the potential for fertility still, oral contraceptive pills may be used for contraceptive benefits. And also, there should be calcium and vitamin D for all. One case that we often see in primary care is in athletes. And it can be challenging in this situation to advise weight gain because that can trigger body concerns. It can be challenging to suggest decreasing exercise because there may be worries about affecting their performance. And so a few suggestions may be helpful. About 10 to 15% of female athletes experience amenorrhea or oligomenorrhea, but it's important to note that this is not a healthy response to exercise, that even for athletes, this is a sign that there's not enough fuel for the body. And we can frame our counseling as the need for energy availability, not weight. So the athlete needs adequate fuel for performance, and the absence of menses is a sign that there's not adequate fuel. We should explain the reversibility and the timeline that it may be up to 12 months for menses to resume. And finally, polycystic ovarian syndrome, now called polyendocrine metabolic ovarian syndrome to more accurately describe this condition. We diagnose it with the Rotterdam criteria and exclude other diseases. And note that clinically, PCOS or PMOS is associated with insulin resistance, infertility, the risk of endometrial cancer, and hyperandrogen symptoms such as hirsutism, and our treatment aims to address these manifestations. In women who are overweight, weight loss can mitigate a lot of these symptoms, but In primary care, we know how challenging weight loss is over time, and the goal is a healthy, lifelong lifestyle, not a short-term intervention. It's also become clear that weight stigma, and not just weight itself, contributes to many of the adverse health consequences of overweight. So it can be helpful to set SMART goals, so measurable, achievable, timely goals, and minimize weight stigma when we're talking about this. Partner with the patient for their goals. Fundamentally, weight management depends on increased exercise and restricted calories, with a goal of 5 to 10% of weight loss, as that shows benefits. And I will note that there are benefits to lifestyle changes even without weight loss. And then the question we're all confronting now is, what about GLP-1 RAs? So these medicines are especially promising for the metabolically high-risk phenotype, so obesity, insulin resistance, and visceral adiposity, but there is sparse PCOS-specific data so far. And third, I'll talk about primary ovarian insufficiency, which is diagnosed with elevated FSH in women under age 40. Should be confirmed after a single measurement. And the diagnosis is needed through testing karyotype, Fragile X premutation screens, adrenal and antithyroid autoantibodies, because the etiologies are quite different than the other conditions we've talked about previously. Management in primary care includes hormone replacement, and that's either estrogen at a replacement level dose with transdermal estradiol, so a dose higher than that which is commonly used for menopausal therapy, and progestin, or birth control pills, again, if contraception is needed, because we may see intermittent ovulation in some of these patients. And hormone replacement should continue until age 50 or 51, the average age of menopause. In addition, calcium and vitamin D should be recommended, and attention should be paid to the emotional impact of this diagnosis, which may include impacts on fertility. And then finally, I will note that early menopause is considered a sex-specific cardiovascular risk enhancer. And so we should think about cardiovascular risk reduction in these patients. So at diagnosis, assessing lipid profile, diabetes screen, and then continuing to monitor for cardiovascular risk factors over time. So that last slide on primary ovarian insufficiency is a nice lead in to the next topic, which is menopause. As Dr. Iyer said, menopause is having a moment, and women in perimenopause and menopause may now be coming to you with a variety of symptoms, ranging from brain fog to joint aches to sleep disturbance to hot flashes, or they may have questions about how to improve their bone or cardiovascular health. So her topic is helpful to equip us to answer these questions. Starting with vasomotor symptoms and menopausal hormone therapy. Hormone therapy is the most effective treatment for vasomotor symptoms. And in addition, it can improve other symptoms of menopause, overall quality of life, and bone health. However, there are some risks, and women will often have these concerns. In particular, our data on the risks comes from the Women's Health Initiative, and I will say this used older versions of menopausal hormone therapy. But that said, with those formulations, estrogen alone for women without a uterus did not show increase in breast cancer risk. There was a small increase in breast cancer risk for estrogen and progesterone, although interestingly, no increase in breast cancer specific mortality. The increase in clot risk, so venous thromboembolism, stroke, or PE, is seen really with the oral versions of estrogen. So the key point here is that the transdermal formulations have a lower clot risk. And the role of hormone therapy in cardiovascular disease overall and in dementia has more nuance. We need to think about the timing of when we start hormone therapy And the timing effect, or the timing hypothesis, is based on the fact that if started early, hormone therapy is associated with improved cardiovascular risk, but when started after age 60 is associated with increased risk. So overall, I think the key takeaway is that there's a need to individualize therapy and use shared decision-making. Now, although hormone therapy is the most effective treatment for vasomotor symptoms, some women either are not candidates for it or prefer not to take it. And there are a lot of non-hormonal options to offer with some new additions to our armamentarium. FDA-approved medications include low-dose paroxetine, and this may offer some ancillary benefits for sleep and mood disturbances that often overlap with vasomotor symptoms. The low dose is less likely to cause side effects like weight gain or decreased libido. I will note that SSRIs are relatively contraindicated with tamoxifen, which is an issue for women taking it after a breast cancer diagnosis. We have two other non-hormonal options that have recently been FDA approved. So the first is fezolinetant, which is an NK3 receptor antagonist, and the second elinzanetant, which is a dual NK1, NK3 receptor antagonist. And the key point here is the need to check LFTs more frequently with fezolinetant, but also at baseline at 3 months with elinzanetant, although data has not shown the same signal of hepatic risk with the elinzanetant. There also are a variety of off-label medications that Dr. Iyer details in her talk, and cognitive behavioral therapy and hypnosis have shown some benefit. I will say that, unfortunately, herbal and other complementary therapies like soy or black cohosh have, although they're used by many women, have not been shown to be effective treatments for vasomotor symptoms. And the other big category of menopausal symptoms is genitourinary syndrome of menopause. This consists of vaginal dryness, irritation, dyspareunia, pain with urination, or recurrent UTIs. And all of this can contribute to poor body image and self-esteem, but is very underreported. So the treatment, I think the clinical pearl here is that you can mix and match. So you can add a little bit of vaginal estrogen externally, even in people who are taking systemic menopausal hormone therapy who still have symptoms of GSM. You can use only as much of it as is needed, so you don't have to do a loading dose if the patient prefers not to do that. There are a variety of other options as well, and if you're interested in learning more about these options, Dr. Iyer's talk has a lot of helpful information. Bone health is another important women's health issue, especially for women at midlife and older. We should offer routine screening for osteoporosis to all women starting at age 65 and to younger women who have a fragility fracture or who have risk factors. And those risk factors include prolonged glucocorticoid use, low weight, a family history of osteoporotic fracture, early menopause, as I mentioned earlier, current smoking, alcohol use, or an X-ray showing osteopenia. And who to treat once you have the DEXA. So again, anyone who has a history of a hip or vertebral fragility fracture, regardless of bone density. And then if they have osteoporosis, so a DEXA T-score less than or equal to 2.5 at the spine, femoral neck, or total hip, or a DEXA T-score between -1 and -2.5, meaning osteopenia, and a FRAX score that shows a 10-year probability of a major osteoporotic fracture more than 20%, or a hip fracture greater than 3%, or a proximal humerus, pelvis, or wrist fracture. So here I put in a link to the FRAX calculator you can get online or through your EMR. And I will add that before starting treatment, you should be comfortable doing a secondary workup for secondary conditions such as vitamin D deficiency, hyperthyroidism, myeloma, or malabsorption. What treatment options do we have? The non-pharmacologic measures form the basis for all of this treatment. So that is if relevant, stop smoking, reduce excess alcohol intake, do weight-bearing and muscle strengthening exercises, take adequate vitamin D and calcium in the diet or supplement if inadequate intake through diet. And then our pharmacologic options include the anti-resorptive treatments of bisphosphonates, raloxifene, and denosumab, and anabolics. And those should be considered in people who have very low bone density or a history of vertebral fracture. And the key point here is that anabolics should be used prior to anti-resorptive agents. And then just a quick note about hormone therapy as prevention for osteoporosis. Hormone therapy has been shown to reduce fractures in postmenopausal persons, and it's FDA approved for prevention of osteoporosis in women at high risk for whom non-estrogen medications are not appropriate. So, really, I would think about this particularly in perimenopausal or early menopausal women who have osteopenia or high risk of osteoporosis and also have bothersome vasomotor symptoms. The USPSTF acknowledges that although hormone therapy is associated with a decreased fracture risk, there is not a clear evidence for benefit. And lastly, I'm going to close with a topic that is close to my own heart. So this is the talk that I presented with my colleague, Jackie Savage-Borney, on a trauma-informed approach to intimate partner violence. I want to emphasize that intimate partner violence is very common. So contact sexual violence, physical violence, or stalking by an intimate partner is reported by almost half of women in the US in their lifetime, and it's associated with many long-term health effects in addition to acute injury. The USPSTF recommends screening reproductive age women, especially during pregnancy. And inquiry about trauma and IPV can be an intervention in and of itself, can destigmatize the condition, create a safe place for disclosure if a person wants to, and can be a way to offer resources for help. There are many barriers to screening for IPV, and probably most salient is the lack of time in healthcare visits, but I do want to focus here on one concern, which is whether it's necessary to share an IPV disclosure with law enforcement, because I get asked about that quite a bit. Because mandatory disclosure to law enforcement can have negative repercussions for patients, it's important to know the rules in your own state. So before inquiry about any kind of intimate partner violence, you should review the limits of confidentiality with your patient. They have the right to decide whether or not to disclose relationship information. And most states do not require reporting of adult IPV, but there are exceptions, and IPV reporting laws differ by state. So I have a link here to a resource that has information by state up to 2019. However, there are always the possibility for changing. Typical areas of concern are abuse of persons with disabilities, older adults or children, and injuries from a weapon. So you should recognize that filing, although necessary, may escalate a situation. So take that into consideration when you're making a safety plan, and don't worry alone. So ask for support, know your local resources and experts. I'll close by describing trauma-informed care, which I have found to be an approach that helps me provide good care for our patients and also acknowledges the challenges of being a clinician working with patients who share their stories of suffering and resilience. TIC aims to create a safe environment for survivors of trauma to engage in care with a universal precautions approach rather than requiring a disclosure. And the TIC principles that I list here can be the basis for improving engagement, mitigating the effects of trauma, and working towards health equity. With that, I'll end by saying that women's health is a rapidly evolving field as emerging data shape new guidelines and best practices. And ongoing learning and a person-centered trauma-informed approach aim to improve care, reduce disparities, and contribute to closing the women's health gap.